Good morning, and thank you for being here and for the opportunity to present this. This is a phase 3 trial of Venetoclax or placebo in combination with Bortezomib dexamethasone in patients with relapsed refractory multiple myeloma. So as you all know, myeloma remains incurable even though we have had multiple new agents that have been developed over the past decade. Even though the survival in myeloma has almost tripled in the past decade and a half, these patients continue to relapse, so there's clearly need for novel therapies, particularly those that are targeted towards the underlying disease biology. So we have known for a long time that pro-survival or pro-anti-apoptotic proteins like the BCL2 family proteins have a clear role in the survival of myeloma cells, especially in the context of other therapies. Venetoclax is a molecule that's already approved for treatment in CLL. Most of you are familiar with. It's a very potent oral, very specific BCL2 inhibitor. And the early studies had shown single agent activity and also activity in combination with Bortezomib and Dexamethasone in relapsed disease in the phase 1-2 trials. So based on the preclinical work as well as the interesting data with the combination in phase 1 and phase 2 studies, this moved ahead to a phase 3 trial. So BELLINI is actually a phase 3 randomized trial in patients with relapsed refractory myeloma with 1 to 3 prior lines of therapy and in patients who are still sensitive to Bortezomib. And these patients were randomized in a 2:1 fashion to either Venetoclax or placebo in combination with standard doses of Bortezomib and Dexamethasone. 291 patients, again 194 patients to the Venetoclax, 97 patients to the placebo arm. And the key primary endpoint was progression-free survival with additional secondary endpoints of response as well as overall survival and quality of life parameters. The progression-free survival was significantly improved by addition of Venetoclax to Bortezomib and Dexamethasone. As you can see here, the progression-free survival was roughly doubled from the 11.5 months with Bortezomib Dexamethasone to 22.4 months with the Venetoclax and Bortezomib Dexamethasone. So the trial did meet its primary endpoint. And the overall response rate, including the minimal residual disease negativity, was significantly better with Venetoclax compared to placebo. And as you can see here, a significant improvement in the complete response rate from 5% to 26% with the addition of Venetoclax. This was also associated with very deep responses, including the MRD negativity, which was substantially higher with Venetoclax compared to 1 to 3%, irrespective of the level of MRD that you are looking at. With the placebo alone. What was surprising in this study was a decreased overall survival in the experimental arm. There was more deaths were observed in the Venetoclax arm compared to the placebo arm. The interim overall survival that was analysis that was looked at the time of the progression-free survival analysis demonstrated an overall 41 deaths in the Venetoclax arm compared to 11 deaths in the placebo arm, and the majority of these deaths appeared to be related to infections in the context of progressive disease, as you can see in the table on the right side. So, in conclusion, the addition of Venetoclax to Bortezomib and Dexamethasone clearly was effective in this group of patients with an increased depth of response, overall response rate, both of which translated to an improvement in the progression-free survival. However, we did observe increased numbers of deaths in the Venetoclax and Bortezomib dexamethasone arm. The majority of the death seems to be associated with infection in the context of disease progression and most of the excess death happened during the first 6 months. And patients, we were able to identify subgroups of patients who did particularly worse, and these included patients who are 1114 negative with low BCL2 expression, high-risk cytogenetics, and ISO stage 3. In contrast, patients with 1114 translocation had a significant benefit, even though there were only 35 patients with 1114 in the study, 20 in the Venetoclax arm and 15 in the placebo arm. The progression-free survival was significantly better for the 1114, and there was no negative overall survival disadvantage for the 11-14 patients. And thank you.
Hi, Neil Ostro with Hematology News. So in March, the FDA suspended most trials of Venetoclax in multiple myeloma.
Correct.
Are there still studies ongoing in subpopulations or?
So the studies were broadly put on hold based on the BELLINI results. Now the FDA, hopefully we will be hearing back from FDA with some definite directions in terms of new accruals to the studies. The ongoing studies such as BELLINI, where patients are still on treatment and getting benefit from treatment, were allowed to continue with supportive, especially with anti-infective prophylaxis.
Okay, thank you.
Any more questions? We still have plenty of time. Is the 11-14 effect just related to levels of BCL2 expression?
Yeah, I think it's a ratio of the BCL2 to the BCLXL or MCL1. That seems even within the 11-14 patients in a phase 1 trial with a single agent, it was a 40% response rate. But if you look at, it's only 9 patients in that group who had a high BCL2, low BCLXL ratio, and 8 of the 9 patients actually had a response. So it seems like the 11-14 enriches for that profile of high BCL2, low BCLXL or MCL1.
It would seem to me somewhat logical to target use of Venetoclax to patients who are likely to benefit from it. So do you think in the future, rather than talking about cytogenetic subgroups, shouldn't we just look for
Right.
the type of ratios that you've just mentioned?
Absolutely. So I think that's kind of the biomarker strategy, but that's probably something that's more longer term. I think the shorter term, the 11-14 patient seems to be a much more easier way to enrich for that patient population. And when you use it in combination with dexamethasone, it's about 65% response rate in the 11-14 patient population.
I would argue that it's not, it may be what we're used to doing, but yes, it is easier to do genetic typing rather than to look at levels of transcripts or proteins. But perhaps we should learn to adapt our prognostic tests based on the reasoning behind it, rather than the surrogate marker.
That would be the ideal goal. It's just the process of getting a biomarker approved to go as a companion to a therapy usually takes a lot of time.
Absolutely.
And the rest of the patient population, the non-11-14, the big question is, does the BCL2 inhibition enhance other existing therapies? At least with the Bortezomib combination, that was the preclinical evidence that there was mechanisms for synergy, which seemed to be borne out by the study, but the toxicity was unanticipated.